Yes.
Okay, we'll cover genitourinary system. You are to cover genitourinary system by Dr. Diwa, who had other engagements. So we do it, hoping that we finish it also in good time, so that we do other engagements in preparation for our end of year examination and the end of term 3 before our end of year exam. So the genitourinary system consists of, or rather comprises, the kidney, ureterus, bladder, and the urethra. But in our setup, the way our curriculum is designed, when you talk of genitourinary system, we also mean part of the reproductive system. So we'll cover the kidneys, ureter, bladder, urethra, and then do our pelvis. I think pelvis, we did pelvis when we were covering the lower lip, so we not dwell so much in the pelvis, but concentrate more on the perineum aspect, where we'll want to cover the the uterus, the ovaries, the reproductive system in a nutshell. That's what we'll do in this outline for the genitourinary system. So I've said the genitourinary system consists of the kidneys, ureter, bladder, and urethra. So we'll cover the anatomy of that. The embryological and histological aspects of the same will be covered by Mr. Rajoro. Your class rep will schedule with him accordingly. In this pictogram, we have the renal, the presentation of the GU system, the gross anatomy. You can see the way the kidney is designed to be a bean-shaped organ. You can appreciate the renal artery and the renal vein. You can appreciate the ureter, bladder, then urethra. So basically, the kidneys are normally two in number, the right and the left. They are located, they are known to be retroperitoneal. During our abdominal presentation, anatomy of the abdomen, we talked of organs that are retroperitoneal, and kidneys are also one of the retroperitoneal organs. Mostly they are located on the posterior abdominal wall on each side of the vertebral column at the level of T12 to L3. The morphology of the kidney, as we all know, the kidney is bean shaped, and the weight of the kidney is normally about 30 to 150 grams. Dimensions of 10 centimeter long, 5 centimeter wide, and 25 centimeter thick. It has two surfaces, the anterior and posterior surface. Two borders, medial that is concave, and lateral that is convex. These are cadaveric representation of the kidneys. You can appreciate the celiac trunk with the superior mesenteric artery, the left adrenal gland, or rather some books will call it the suprarenal gland. You can appreciate the right renal vein, the right renal artery. Then the abdominal aorta as it descends. So normally if you do a kidney transplant, the remaining kidney normally undergoes some morphological reorganization, where it now enlarges to compensate for lack or rather loss of the other kidney. That compensation can also occur if you have the renal artery stenosis, so that one kidney is not getting more blood supply compared to, is getting less blood supply compared to the other kidney. So the other kidney that gets adequate supply undergoes hypertrophy to compensate for the same. But such patients normally end up with high blood pressure because of renal artery stenosis. The coverings of the kidneys inside out, again, just to mention, you can survive, you can live a healthy, normal life with one kidney. For those of you who want to donate and get out of the block, I mean, locally we say kuomoka. You donate one of your kidney and stay. You can live a healthy life with only one kidney. as you pocket your 3 million or 4 million from that deal. But again, at times you can get kidney failure later on and now look for that other person that I want my kidney back. Those are now the challenges that happen after you donate one kidney. So the coverings of the kidney include the renal capsule, the perirenal fat, renal fascia, which is a connective tissue of, or rather continuation of fascia transversalis, and the diaphragmatic fascia. Then we have the pararenal fat. Those are the covering from inside out. So if we talk about relations in anatomy, we mean what other structures are bordering that organ. For example, in posterior relations of the kidney, we have 4 muscles. In an exam, if we say the following are posterior relations of the kidneys, except. So it should be very, very charged when you come. So the diaphragm is a part of the posterior relations, that is the crurus. We have the chordatus lumborum, transversus abdominis, and the psoas major from the 4 muscles that relate the kidney posteriorly. Neurovascular structures, we have a subcostal nerve, subcostal vein, iliogastric nerve, and iliolinguinal nerves. The anterior relations of the kidney, we have the suprarenal gland, second part of the duodenum, right lobe of the liver, small intestine, and ascending colon. The left part, suprarenal gland, again, like the right part, if you say suprarenal gland, we mean now the right side of the right suprarenal gland, or adrenal gland, as some books will put it. You have the spleen on the left part, stomach, body of pancreas, and descending colon. And finally, the coils of jejunum. So how is this structure of the kidney really? We have the coronal section, where it has the outer pala cortex, like it's pale, like not darker, while the inner part is dark. The medulla, pala should be single L. The medulla is organized into conical structures that are referred to as pyramids. That's the part of the cortex between the pyramids is called the renal columns. The tips of the pyramids invaginating the minor calyces are called renal papilla. So like in this pictogram presentation, you can appreciate the major calyces, you can appreciate the renal pelvis, you have the sinuses, renal corpuscle. So for those of you who will do histology, especially dental students, you must appreciate that, how it looks in histology. Blood supply, renal arteries from the aorta, renal veins from the inferior vena cava, the allobular and interlobular arcuates, interlobular afferent arterioles, and also the glomeruli. So the main blood supply just talk of renal arteries. So you must know where the left renal vein and right renal vein come from. That's a good anatomical difference, where the veins drain. So about that one I will ask. Go check how the renal veins are arranged for the left kidney and the right. So the ureters, now from the kidney down, when it gives you that connects us between that organ, the bean-shaped organ kidney, to the bladder. That's the ureter. So normally it's a muscular duct of 25 to 30 centimeters. Still, it's also retroperitoneal. It's a conduit of urine kidney to bladder, as I've said. And of course, it also has to have the transitional epithelium because it's under a lot of stress and irritation from concentrated urine. So it has 3 areas of constriction. That's an important anatomical variation. We have the junction of the ureter and the renal pelvis, where the ureters cross the pelvic brim and where the ureter pass through the wall of the bladder. That's an important anatomical variation, those three areas of constrictions of the ureter. So why are they important? Because if you get a renal stone, those of you will do renal specialization, especially the nurses for this group. You can specialize as a renal nurse. So if you specialize as a renal nurse, there are patients who will come with the kidney stones. With kidney stones, you find now, depending on the number of the kidney stones, you can do what you call trans, shockwave lithotripsy. It's called extracorporeal shockwave lithotripsy. So if you do extracorporeal shockwave lithotripsy, you tend to pass some sounds or some vibrations onto the kidney so that the stones that are in the kidney can fall off. For example, if there are stones here, and this is the ureter, we have the stones in the renal pelvis in here. You can see my cursor, right? Nema Jemuta.
Yes.
Yes, if you have the renal stones here, and now they have concentrated here, the patient is in pain and all that. So you pass your shock waves. There are waves, there are some vibration that you pass called extracorporeal shock waves. So these stones will, because of the wave, the stones can move and now drop into the ureter and then finally into the bladder. So if these constrictions are much, their constrictions, the constrictions are very significant at the level of the junction of the ureter and the renal pelvis, where the ureter crosses the pelvic brim, where the ureter passes through the walls of the bladder. These stones can be also be held there, so that now your lithotripsy can fail because of increased, further narrowing of the lumen of the ureter. So the renal pelvis is expanded upper is the expanded upper end of the ureter and divides into major calyces and minor calyces. That one you have seen in the pictogram. The blood supply, you have the linear artery, the gonadal artery, the abdominal aorta. So for those who will do the steeplechase, we can tag you, the dental students. They are the ones who do the practical. We can tag the ureter, then ask you, give us the blood supply of the structure marked. They're interested in you saying the renal artery, gonadal artery, abdominal aorta. Then others are common iliac artery and internal iliac artery, inferior vesicular arteries, and the uterine arteries in females. Okay. So the veins, you have the renal gonadal veins, lymphatics, aortic, common iliac, and internal iliac nodes. Then to urinary bladder is a hollow viscous with strong muscular walls called the trusor muscle. So the average capacity that urinary bladder can hold is 300 to 400 ml in adults. Located in true pelvis, posterior to the pubic symphysis, and anterior to the rectum in males and vagina in females. So in children, it's an abdominal organ. As you grow further, it becomes a pelvic organ. The shape, size, and location are affected by the amount of urine that is in there. For example, some people are unable to have a lot of urine because of irritation. Irritation in the urinary bladder can be as a result of issues like you have UTI, where now the bladder is irritated, just a little urine you want to go and empty. For example, if you can have urinary bladder stones, can also impact on the capacity of urine. Other masses in the bladder, for example, adenocarcinoma of the bladder, can also reduce the capacity of the bladder. So this patient, we have to beware of such patients. Other irritations can be as a result of infections, like for the schistosoma, hematobium. They can also give you irritation of the urinary bladder, causing hematuria. Hematuria is now bloody urine. So bloody urine can occur as a result of infections. For example, you have cystitis. Cystitis is not inflammation of a cyst, but now infection of the urinary bladder is generally referred to as cystitis. So if you have infection of the bladder, And if it is schistosomiasis, for example, schistosoma hematobium, patient will come say, when I pee, towards the end of my pee, I get blood urine, which you call terminal hematuria. Then that you know, likely we are really dealing with schistosoma. You also look at other history, for example, history of where they stay near a large water body. They are around the lake, where there's flooded areas, in Budalangi and such like areas. They like to get schistosomiasis. If they are elderly, of course, like we are dealing with, cancer could be cancer of the prostate, bladder CA, bladder stones. Those are the issues we will be dealing with. If there is fever involved, of course, you know this just be acute cystitis, or rather infection of the urinary bladder. So this is the pictogram representation. You can see this is a female cross section, sagittal section. You can appreciate the urinary bladder, which is here. We say this anterior to the uterus in females. So this is the uterus. Then this is the vesicouterine pouch, also called as the pouch of. Then there's this pouch here, which is called the pouch of Douglas. So the pouch of Douglas will meet it. If you read most of the ultrasound, it'll be telling you there is no free fluid in pouch of Douglas, or some people say in cul-de-sac. So if there is free fluid here, mostly it means that this patient has pelvic inflammatory disease. Not all of them. Now you look at the symptoms. That patient has suprapubic pain or pain during sexual intercourse. So if you find such kind of pain, then also there is a ultrasound says there is free fluid in cul-de-sac, or rather in pouch of Douglas. That means there is high chance that this patient has pelvic inflammatory disease. You can appreciate where the vagina is, the urethra, the pubic symphysis. So the morphology, when empty is transhedral, the way now the bladder is, when empty, when full, you must appreciate that. I'm not going into such details for now. The surfaces of the bladder, we have the superior surface, inferior lateral surface, and the median umbilical ligament. You can appreciate. You can appreciate how the ureter enters and how the membranous urethra leaves. You can see where the prostate is. This is just an topical presentation. Again, same thing. This is the trusor muscle, the muscle that contracts depending on the parasympathetic or sympathetic stimulation. You can see the urethra and the external urethral sphincter. Okay. Peritoneal relations in males and in females that we must know. How it forms the two pouches, the pouch of Douglas and the uterovesical pouches in females, while in males it forms the rectum and the rectovesicular pouches. Those are the peritoneal reflections. So at your own free time, you can also go through that pictogram representation of the same. The walls of the bladder has 4 layers: the mucosa, submucosa, the muscular layer, which we said is called the detrusor muscle, has 3 layers: the longitudinal, circular, and longitudinal. So not circular, longitudinal, circular. It's longitudinal, circular, longitudinal. So the circular one is the one that also forms the internal sphincter of the blood. Then we have the serosa that is covered by the peritoneum. Blood supply to the bladder, branches of the internal iliac artery, superior vesical artery, inferior vesical artery, vaginal artery, and ureter artery, and inferior gluteal arteries. Venous drainage. The veins collect themselves into visceral venous plexus, which combine, forms like a connexus. Normally drain into the internal iliac vein. The innervation of the bladder, as we indicated, through normally sympathetic and parasympathetics. Parasympathetic from S2 to S4, while sympathetic arises from the epigastric plexus, T11 to L2. You can also have inhibition. For example, when you talk in physiology, when you talk about the reflex, micturition reflex, normally the intention to pass urine or to micturate comes depending on how much urine that there is, about 800 to 1200 ml. But now we'll activate the stretch receptors as from 200 to 400. So once that stretch receptors are activated, your brain senses that now there's some urine here and I need to pee. So also there is that inhibition aspect where, depending on where you are, for us men, the society takes good care of us. We can pee anywhere as long as there is some bush somewhere. We can just go and. But for females, their brains are wired in such a way that the pudendal nerve will now inhibit the external sphincter so that we avoid voiding, depending on whether the environment is conducive or not. So in a place where there are a lot of people, there is no toilet, so there is a way we are wired to inhibit the micturition reflex. But that's more physiology than anatomy. For anatomy, what we need you to know, that the detrusor muscle can relax and contract depending on the amount of urine that there is when the stretch receptors are activated. Parasympathetics S2 to S4, sympathetics from T1, T11 to L2. That was the presentation for the day. So we'll meet next time and cover much more, mostly the perineum aspect. We'll cover the prostate, the internal and external genitalia in males and females, the superficial and the deep perineal pouches. Any question up to that point? Any question?
Excuse me, sir.
Yes, Joseph.
Yeah, Sam, you said you will protect our mark. So how is it?
Protect what?
You will protect our JC anat mark.
You people, you refused one. You said you will come individually to see the marks at the secretary's office.
No, I changed my mind. It was me alone.
So you can come. You can come if you are available. You are around. You can come to the office. Your marks will get to see your marks.
Okay.
Or what is the consensus? We project.
Yeah.
Okay. Let me see if I can get the marks straight away. Project.
Yeah.